in this very unique space in American geography called Northern Virginia, which means that we have, to my experience, a lot of people who know a lot of things. And I think that's a resource that a church should take advantage of. And you're going to see that tonight in the two speakers that we have. We're going to be talking tonight about health care and the Affordable Care Act, and we're going to be talking about related issues. And so part of what I want you to know is sort of the ground rules that we've talked about, and I didn't even call them ground rules. The nice thing about these two gentlemen is they recommended each other to me, and in really kind ways. But what we're trying to do is not only have a really good conversation about an important issue in our country, but we want to have it in a very civil fashion. And we want to have that in a way that people feel like they're fairly heard. And we wanted to have questions, really good questions. So we took questions from you all ahead of time through the e-note and other forms. And I have those. And then tonight, during the presentations, our format's going to be that each person will get 10 minutes to sort of talk about their view of these issues. And Wendell is going to go first because that's what we all agreed to ahead of time. And he, because of the way their presentations are, and Brian said, yeah, that sounds like a good way to go. And I said, good, let's do it that way. And then Brian will follow, and they're each going to get about 10 minutes, and I'm going to watch my clock and give them 3, 2, 1, that kind of thing. But we're not, let me tell you what this is not. This is not a debate. This is a conversation.
Well, good evening. I want to thank Tom and Brian for doing this. I hope at the end of this session you'll be more knowledgeable about what the Affordable Care Act and that we educate you. And, I think it's very hard in this political season with a 1-minute soundbite to really understand what this is all about. And I think healthcare is going to be a big issue from now until election year. And the Affordable Care Act, still hasn't reached great heights of popularity by any stretch of the imagination. So what I want to do, first of all, is just give you 2 or 3 slides on the basics of why we did the Affordable Care Act, what some key facts are about the health system. Then I'm going to briefly describe the Affordable Care Act, and then...
Let me maybe move right here,
because
the people over here can't see your screen.
Oh.
Is that true? So let's go ahead and get you here. Do you want to...
No, I'm good. I'm good. I can keep...
I'm sorry to break your flow.
No problem. So really the thing we tried to do in the Affordable Care Act, we had 47 million Americans, about 18% of the non-elderly population. Almost all of the elderly are insured through Medicare. Before reform, they were underinsured. By that I mean they had skinny plans if you had a catastrophic operation of some kind, and the per capita spending of the top 1% is $90,000 a year. I'm going to come back to that. In cost, healthcare represented 17% of our GDP. That's 5 to 6 percentage points more than any other European country, and those costs were typically rising at low double-digit rates. And then the quality. We had hospitals that varied a lot in readmissions rate. We have hospital-acquired infections. There were lots of things wrong in terms of a quality standpoint with the health system. And to make a short story, we did something about the uninsured. We're going to be at the issues of cost and quality forever. ACA was a step in the right direction. It's not the end-all and be-all. How did people get insured before the Affordable Care Act? We have the Medicaid program, which the federal government pays on average 57 cents on the dollar. It varies from 50% to richer states like New York and California, to the Mississippis and Alabamas. It goes up to about 78%. And the states got to decide eligibility. They got to decide how they're going to constrain cost. They basically wrote the rules of the Medicaid program. There were some rules that the federal government says, like you had to treat people in Richmond the same way you treat them in Fairfax County. a few things like that. But for the most part, the state of Virginia determines the rules. Medicare, everybody over the age 65 who has been in the labor force or has a spouse that has been in the labor force is covered through Medicare. And then the very severely disabled. There's about 9 million people below 65 that get Social Security disability insurance. Then we have the employer market. And you have the group employer, the Fortune 500. Almost every employer, retail, fast food doesn't do this, but your Fortune 500, you get health care through your employer. Now, employees may have to pay part of it, but your employer, maybe in some negotiations with the employees, determines what the health policy covers, et cetera. And so we have about 155 million Americans that are covered through employer coverage. And why did we connect that to employers? Well, there's 2 main reasons. One is the tax treatment. If you get benefits from your employer, and that could be a benefit of maybe $15,000, you don't have to pay federal income tax on that, and you don't have to pay Social Security payroll taxes. And from the point of view of the health insurance company, they got to sell it all at once. You know, if they can get General Motors to do it, they have, you know, whatever the size of that workforce is. And most importantly, they have a big pool. They have people who are going to use the system maybe in a year, and then they have some healthy people that aren't going to use that insurance during the year. So that's why health insurance is tied to employment. Now, the part that was broken, the individual market, who's in that? It's the uninsured, it's the self-employed business person, it's the farmers, things like that, where you have a very small group. And what the insurance companies did, and it's not their fault, but you know, they wanted to avoid risk. So they did a lot of underwriting. They asked you questions. Did you have a heart attack? Does your child have type 1 diabetes, et cetera? And then, depending upon what the answers to that was, they said, no, we're not insuring you because you're going to the chances are you're going to cost us a lot. And so we had a very broken individual market. So some facts about health spending: the average individual spends $6,200. The average family cost now is $17,500, and these costs rise with age. So before the Affordable Care Act, someone like a 64-year-old is about 5 to 6 times as expensive as the average 22-year-old. Females are more expensive. Has nothing to do. It's mainly due with the fact that females produce babies, and that tends to increase cost. The spending distribution is incredibly skewed. In a given year, the most expensive 5% spend 50% of the healthcare cost. The bottom half, the most healthy in a given year, spend just 3%. And that's why you need insurance. So insurance is almost like a necessary evil. It has wonderful benefits. Your bills are taken care of. My son was hit by a car and thrown from here to that camera. His bill in Memorial Hermann was $200,000. Probably, I should have up a little bit when I think about it, but you know, that's what insurance does. Federal law requires hospitals to treat all individuals. So when you go to Fairfax General, if you have insurance or don't, or the homeless that are taken care of here by Floris, they have to provide that same kind of care. The average uninsured person will spend about 60% because they do go to the emergency room. So it's not like we took people with zero and gave them an insurance policy. They are, and you know, some of the uninsured do pay, and it's the greatest cause of personal bankruptcy. So that's the background. What did the Affordable Care Act do? We said to the insurance company, you had to guarantee coverage, you had to offer the same policy, if you will, and you couldn't discriminate on their medical condition. The only thing you could discriminate on, I can tell you a little story on, is whether you smoked or smoking and your age. Those are the only two things you can rate on. And then there's the individual mandate, the most unpopular part of the Affordable Care Act, where we said to Americans, you must get a health insurance policy. And to my way of thinking, that's personal responsibility. Why should my hospital bills, if I should have to go, be paid by you? Now, it, again, is very controversial, and there was a tax penalty of $6.95 today in 2016 per person, I think up to 3 people, or 2.5% of your AGI, whichever is higher. And then we subsidize that coverage if you're below 138% of poverty. And I should have said one about Medicaid. So if you're disabled, if you're elderly, if you're a mother with children, you're covered through Medicaid. If you're a single childless individual age 40, you can't get Medicaid even if your income is low. So we said you had to cover everybody below 138%, and your subsidies started at high at 139% of poverty and then phased out at 400% of poverty. What did we really do? We said, we're going to take the state with the lowest uninsured rate and we're going to copy it. That state happened to be Massachusetts, and a governor and a Democratic legislature there wrote a bill that is very similar to the Affordable Care Act. So if you look at, and this chart was not prepared by me, it was prepared by Stuart Altman, who was an assistant secretary under President Nixon. The Nixon plan, the Dole-Chafee plan that was written in response to the Clinton welfare health bill in the 93, 94 era, and the Romney. They're based on private insurance. There was an employer mandate. There were small employer subsidies. Most of them had an individual mandate. My point is that we basically copied a very conservative Republican idea because we could not have the votes. We did not have the votes for a Medicare type all plan, a Bernie Sanders plan, et cetera, et cetera. We planted many cost control seeds. I'll call them cost control seeds. We had comparative effectiveness research. So to help, if there's a new technology, is it better than the old technology? Patient-centered medical homes. I'm not health. We try to get every hospital and physician wired with health information technology. We penalized hospitals that have excessive readmissions rates, et cetera. We gave incentives to reduce the number of errors and treatment mistakes. We tried to steer people from the emergency room to routine care. And just to give you some idea, this is my show and tell document. This is the Affordable Care Act. I mean, this is all legal language, but those are all the things we were trying to do in here. So is it working? I think it is. We have insured 20 million individuals, about 6 times the number of people in my home state of Iowa. The rate of uninsured had fallen 37%. 129 million Americans with pre-existing conditions no longer have to worry about losing their coverage. But 4 million Americans are still in the Medicaid coverage gap. 19 states, including our great state, has not chosen to do Medicaid. We've restrained healthcare costs, and this isn't all due to the ACA. I want to make that very clear. But I think the ACA gets some coverage. Healthcare costs have grown at their slowest rate. And premiums for employer-sponsored coverage grew just 4.2% in 2015, down from an average of about 8% in the decade of the 2000s. And we've improved healthcare quality. There's 150,000 fewer hospital readmissions, a 17% reduction in hospital-acquired conditions. And again, I want to make very clear that is not all due to the ACA. This is a slide from the Council of Economic Advisors. We did not increase the deficit. We paid for the Affordable Care Act. Here's my arguments. I can give you a moral argument. I mean, I don't see why the poor in this state should have, shouldn't have access to health insurance. About 300,000 to 400,000 would if the state of Virginia would expand it. And for the 3 years, 2014, 15, and 16, there wouldn't have been any cost to the state of Virginia. It was completely federally financed. And yet states are turning it down. The states, eventually, it goes to a 90-10 matching rate. I ask you the question, would Virginia turn down transportation spending where the federal government offered to spend 90%? And I think it's only fair. Hospitals have to take care of patients that show up at their emergency rooms, that somebody shouldn't get reimbursed, they should get reimbursed for that. So here is the states in yellow that haven't expanded. I'm not going to accuse Brian of being racism, but I think there is some pattern there. And it turns out that the southern states had the lowest Medicaid eligibility levels. So they were at 50, 60%. The Minnesotas of the world were already at 130, 140%. So it's really the southern states that could gain the most in terms of insuring their population. I'm not going to have time to go through these myths. Just remember, there were no death panels. There wasn't a government takeover of healthcare reform. It doesn't add to the federal debt. And one of the things you heard all the time was it cut Medicare by $700 billion. What it did, we improved Medicare. We actually improved Medicare benefits, but we lowered the cost by constraining providers in their reimbursement. This slide says, we have some tweaks we need to make to it. And then finally, these are some other healthcare issues that could come up. How to finance, most of you, not all of you, but some of you are over 65. How we're going to finance Social Security, Medicare, and Medicaid. Emergency funding for SECA. Drug prices are an issue. And the whole issue of medical liability. But with that, thank you. And
thank you, Wendell. Yeah, thank you very much. In case you're a clock watcher and you're concerned about equity, sometimes when we give lay people speaking time, they just go over their assignment around here. And I'm always like, can't you stop? And they're like, no, and they keep going, but I don't want to stop. And seriously, thank you very much, all kidding aside. So what I'm going to do is Brian will have the same amount of time, and I really am keeping an eye on that. But I'm not too worried about it, frankly. But I did want to get that little jab in about our lay people.
So in December, I found out that Wendell Primus goes to Floris, and I was very excited because Wendell is really influential in healthcare policy, and that was just very exciting for me to find out. And I had a wonderful conversation with Wendell and his wife, and they were going to the 11 o'clock service, and we go almost always to the 9:15 service. And after the 9:15 service, we're out in the common area, and they were having a discussion because they do a small group before the 11 o'clock service on social justice issues and Virginia Medicaid expansion. And Wendell's wife, I don't know if she remembers saying this, said, I'd really like to understand the other side of the issues. And I was like, as it happens, this morning in the Richmond Times-Dispatch, I have an op-ed titled, Medicaid Needs Reform, Not Expansion. I'm very happy to be here and to participate. I am really fortunate to get to work on healthcare policy. Healthcare policy is fascinating. I spent 4.5 years on Capitol Hill, largely working on the implementation of the Affordable Care Act and doing oversight of the implementation of the Affordable Care Act. I don't think the Affordable Care Act has been successful. The first research paper that I wrote for the Mercatus Center was titled Downgrading the Affordable Care Act, Unattractive Health Insurance and Lower Enrollment. And what I did in that paper is compare what the expectations were in 2010 when the law passed, largely around enrollment and the stability of the exchange risk pools, and compare it with what's actually going on. And as it turns out, we have much lower enrollment in the exchanges and exchange risk pools that have thus far consisted disproportionately of older and less healthy people, also poorer people. If people aren't getting the large subsidies that Wendell talked about, they are really not buying the health insurance in the exchanges, and it's leading to significant problems. Health insurance companies have made significant losses over the first 2 years of the program, and these losses have come despite pretty large assistance that the insurers have gotten in the first 3 years of the program to get the program up and started. So I'm going to leave it there on the Affordable Care Act for now. I put together a presentation that is somewhat different than Wendell's. Wendell went through a lot of important facts and information about the American healthcare system. I want to start with next week's cover of Time magazine. So Tom used last week's cover of Time magazine in his sermon yesterday, so I figured this was an appropriate place for me to start. I just came across this morning. And it says, dear reader, you owe $42,998.12. That's what every American man, woman, and child would need to pay to erase the $13.9 trillion U.S. debt. This really matters for me because Tom mentioned that we have 4 kids. My wife is actually pregnant with our 5th kid. So this is a lot of debt that my family is taking on. The debt is a real burden, and the U.S. is on an unsustainable fiscal path, and largely that's because of promises that government has made through health care and entitlement programs, so Medicare, Medicaid, and Social Security. And the key question that I want really to address and to spend our time thinking about is, are we getting value for all of what we spend on healthcare? So to start out, I think I'm an economist. There are 3 key principles to evaluate any public policy. One, and this is a pretty famous economist, Thomas Sowell, said there are no solutions to public policy questions. There's only trade-offs. Okay, trade-offs always exist. When government spends $1 on healthcare, that's one less dollar it has to spend on education. It's one less dollar it has to spend on transportation. Right? It can't spend that dollar twice. You want me to stand over here? Okay. Oh, the stand. Thank you. Number 2, everything, including healthcare, has costs and benefits. And what we need to do is compare the benefits and the costs at the margin. Like, are we getting additional benefit for each dollar that we spend? The third principle to keep in mind is that incentives matter, and you have to think, how do policy changes affect people's incentives and what people do? Okay, I'm going to argue that the main problem with American healthcare is that we spend an enormous amount of money on services that do little, if any, good, and that aren't worth the cost. Okay, some examples, okay, because you might not believe me. Institute of Medicine in 2012 released a report that in that previous year, the U.S. spent $750 billion through healthcare on stuff that did nobody any good. There are lots of studies looking at the effect of healthcare on people's health outcomes. Right? Some of these studies, if you have a sort of statistics background, there's a difference between correlation and causation, and trying to find out if there's a causal link between healthcare, between health insurance, healthcare, and health outcomes is very difficult. The U.S. has run 2 health insurance experiments. In 1974, the U.S. government paid $50 million to assign people randomly to basically free medicine or health insurance that had significant copays. They did this in 6 cities. They followed these people for a period of 8 years. and they assessed what the health outcomes were. I'll tell you what the results are in a sec. Oregon Medicaid experiment is more recent. In 2008, Oregon had some extra money to expand its Medicaid program. But they couldn't expand it to a huge eligibility group. They had a limited number of slots. They assigned them through a lottery. So if you won the lottery, you got on Medicaid. If you didn't win the lottery, you didn't get on Medicaid. It allows researchers to compare, all right, what was the benefit of being on Medicaid? Because you can compare the outcomes of people that gained Medicaid with the outcomes of people that didn't gain Medicaid. The really surprising finding from these experiments is that health insurance didn't matter. So in the Oregon Medicaid experiment, they looked at three metrics of health. They looked at blood pressure, blood sugar, and cholesterol. No statistically significant difference. The people that had Medicaid and the people that didn't have Medicaid. The RAND health insurance experiment, right? They followed people for longer. No statistically, so they found, and I should say, both of these experiments, they found people that had free health care, free health insurance, so they went to the doctor, they didn't have to pay anything, or they got Medicaid, used a lot more health care. They used 30 to 40% more health care on average, right? Take away from these experiments that extra health care didn't do those people much good, if any good. Okay, now how can this be, right? How can health care not be as important for people's health as basically everyone thinks? This is a really interesting study written by Atul Gawande, who is a medical doctor and who writes he writes lots of sort of very interesting commentaries on healthcare. And he wrote this article titled Overkill: An avalanche of unnecessary medical care is harming patients physically and financially. What can we do about it? And let me give you a couple of examples. So number one problem is we overprescribe prescription drugs. So you think people often go to the doctor, they're not feeling well, you can't tell whether an infection is bacterial or viral, right? Antibiotics do no good against viral infections. Yet people really like, when they go to the doctor, for the doctor to tell them that there's something wrong with them and to prescribe them medication, right? There's a significant problem of an overprescription of antibiotics, right? And that is causing actually potentially serious problems like bacterial resistant, antibiotic resistant bacteria. Second potential problem with too much medicine, right? When you get tests carry their own risks with them. So a lot of tests are accompanied with radiation, right? In the long run, exposure to too much radiation isn't good for people. But I think the big issue, and Gawande refers to these things as turtles. It's like things that you detect from tests that will never give you a problem. He refers to this as overdiagnosis, and here's what he writes about this. We now have a vast and costly healthcare industry devoted to finding and responding to turtles. Our ever more sensitive technologies turn up more and more abnormalities, cancers, clogged arteries, damaged-looking knees and backs that aren't actually causing problems and never will. And when we doctors try to fix them, the result is often more harm than good. This is another interesting study, and I feel I need to give several pieces of data here because what I'm saying is sort of against conventional wisdom that medicine is miraculous. A Cochrane review is a review of the academic literature on a healthcare issue. So these researchers looked at 18 studies that assessed the benefits from general health checks. Their conclusion: general health checks did not reduce morbidity or mortality and are unlikely to be beneficial, right? Pretty surprising. This article also appeared last week in U.S. News and World Report, and the title is "Fat, Your Doctor Can't Help. Most doctors don't feel comfortable addressing nutrition and exercise," which is really unfortunate because when you look at studies, right, of what affects health, Nutrition and exercise routinely come as two of the most important factors for what affects people's health, right? But the medical system that we built, not very good for dealing with those things. Okay. Government policy, starting with the tax exclusion for employer-sponsored insurance, and I'm going to go through a couple more problems with the tax exclusion. But government policy generally encourages the overconsumption of health care by heavily subsidizing comprehensive health insurance. So the example that Wendell gave of his son, that is what people should have health insurance for. Low probability, high catastrophic events, right? You have a $200,000 medical bill, that's why you purchase health insurance. But in the US, we increasingly pay everything through health insurance. You go for a physical, health insurance, right? You have small out-of-pocket costs. Health insurance covers everything. And when health insurance covers things that are routine, right, there's a bureaucracy that develops. There's insurance company getting in between the doctor and the patient, right? There's lots of adverse problems. And government policy for 80 years has led to overinsurance and the resulting overtreatment. The tax exclusion does encourage employers to provide really generous health insurance to employees. Well, what does that come out of? That comes out of people's wages, right? Otherwise, people would be making higher wages. The second issue is when insurance is tied to work, right? That means you lose your job, you lose your health insurance. That's a significant problem. Medicare and Medicaid. So Medicare and Medicaid, again, heavily subsidize medicine and healthcare. Medicare sets prices throughout the healthcare system, right? Often these prices are too low or too high. So one example of Medicare setting too high prices is generally for cardiology care. Because doctors have responded to these high prices, high reimbursement rates, a lot of people have gone into cardiology, and one of the most common procedures that people have done that we now learn really wasn't that beneficial are stents, right? Medicare paid an enormous amount of money for cardiologists to put stents in people. Now it turns out, I think this is a pretty big study last week, that putting stents in people really didn't do much to clear their arteries. Medicare often also underpays. So we have an issue in the US of an aging population. An aging population could use doctors who were just concerned with the needs of older people, right? But Medicare underpays for geriatric services. So you don't have people in medical school going and specializing in gerontology, right? They go and specialize in cardiology or orthopedic surgeons, which, again, there's a lot of overtreatment in addition to cardiology, like a lot of unnecessary back surgeries. I mean, there's lots of evidence that when you compare people's outcomes, if they have back surgery or they do conservative treatment, that on average, there's no difference between the two groups. And we have the affordable, so Medicaid, Wendell mentioned Medicaid. I wrote my dissertation on Medicaid financing. Wendell gave the analogy of, I think, why would a state turn down 90% reimbursement rate for anything, healthcare or transportation? I'd say the federal government should never be giving states that option, right? The federal government should never say, we're going to give a state a blank check and cover a vast majority of their spending in any area. In Medicare, it misaligns the incentives. States, because every dollar that they spend on Medicaid, they get a huge influx of federal money. They overspend on Medicaid to get that federal money. And you get arguments like states should expand Medicaid because of the economic benefits instead of the health care benefits, right? Even though that money, that cost is being paid from somebody. Finally, Tom, give me 1 minute to finish this slide. I gave a lot of sort of problems with the healthcare system. Let me say, I do think there are some things we can look at that are reason to be optimistic, and that there are some things that we can look at in healthcare markets for how to reform the system more broadly. So laser eye surgery and cosmetic surgery, those areas we've seen declining prices and higher quality, right? In those two areas, providers compete directly for consumers. Insurance doesn't cover those. Reference pricing. So reference pricing, the example of this in California, Wellmark had contract with the state employees, and they wanted to figure out how, the state employees were getting hip replacements. I think hip replacements, could have been knee replacements, it doesn't matter. The cost at facilities throughout the state varied widely. And one of the things that's weird in healthcare is quality very rarely depends on whether you go to a low-cost provider or a high-cost provider. So the insurer was trying to figure out how can we encourage and get better outcomes here for people. And what they did is they set an fixed amount of money that they would pay. So if the range was, say, $30,000 to $90,000, they might have picked $50,000. All right, we're going to pay $50,000. So what did patients do? They went to, they asked what the price was for the procedure, right? With third-party payment, often consumers don't have any incentive to ask what the price is for a procedure. So they asked what the price was, so they were competing on price. They were making choices based on price, which is what we do in every other part of the economy. And over time, the high-cost producers lowered their prices, right? They came down to the equilibrium. So the facilities that were charging $90,000 brought their prices down to $50,000. Finally, health savings accounts. Health savings accounts were signed into law by President Bush in 2003. Health savings accounts are linked to a high-deductible health insurance policy. Health savings accounts underneath that deductible, health savings accounts allow sort of market forces to work and people to spend from their own resources. Wendell mentioned that healthcare inflation has lowered since the passage of Obamacare. I think most economists attribute that to two factors. One, the introduction of health savings accounts and insurance incorporating those features, and then the very deep recession and pretty weak economic recovery that healthcare spending is the normal good, right? People spend more on it when they have more income, and the recession was, I think, probably the key factor in the healthcare inflation slowdown. Okay, thank you.
Show our appreciation. Thank you. All right, thank you very much. So if you've got questions that have been developed during that time, that was on this stage. Thanks. During that time, raise your hand, and Bill's going to bring you the cards and the pens, and just kind of keep your hand up, and he's going to get to you. So thank you. We did receive questions ahead of time, and so here are some of those questions. These are not my questions. These are questions that people in the church sent in. So if you all find that the question itself is flawed, you can deal with that, and you will not hurt my feelings. The Republican side is eager to repeal Obamacare. What is the alternative if the Affordable Care Act is abolished? If the solution is to grant tax credits to pay for health care, how does this help the poor who don't make enough money, who don't make enough to pay taxes due to the earned income credit?
So I should take this one.
Yeah, well, it's your time, gentlemen.
So I think the main problem with the Affordable Care Act is that it restricted the choice that people have over what type of health insurance to buy. So the ACA requires that insurance cover a pretty expensive set of benefits. All insurance has to be in sort of these narrow actuarial bands. Insurance has to cover preventative services with no patient cost sharing. And insurance, as Wendell mentioned, they put price controls on insurance. So guaranteed, insurers had to offer coverage to everyone, and they couldn't give discounts based on whether someone was healthier, and they could give discounts based on someone was younger, but not to reflect sort of how little younger Americans spend on health insurance. So what that resulted in is the average price of insurance pretty significantly increasing because of the ACA. So, I mean, I would advocate that any replacement plan, and it's not like insurance was regulated well before the ACA, so states regulated insurance, and some states had lots of health insurance mandates and other states had fewer. But I'd say the first thing we need to do is be able to allow people to buy a health insurance product that they think is best for them. I think, secondly, we need to change the way we subsidize health insurance. So I would be in favor of sort of moving to fixed support instead of sort of sliding scale subsidies, which when you base a subsidy on your income and the subsidy declines as you earn additional income, that presents an incentive for people to work less and make less money. And I don't think, and there's already a ton of that in government programs, I don't think we need to structure government programs in a way that disincentivizes people to work and try to improve their lot.
Wendell, do you want to reply to that question? Do you want to hear the question again?
No. So for the last 6 years, the Republicans have kind of promised that they were going to have an alternative. And in fact, Speaker Ryan and the relevant chairs of the House committees are working on a response. But I think at the end of the day, there's no other way. I mean, if you're dealing with someone who has very little income and you solve the premium price up there, you've got to provide nearly free care. Now, we can quibble a little bit about that. And then, actually, the Affordable Care Act gives you lots of choices. We have something called a platinum tier, a gold tier, a silver tier, and a bronze tier. We tie the subsidy to the second lowest silver plan. So insurance companies come in and say, we bid. And then if you go on healthcare.gov, which was a terrible rollout, it was horrible. They should have done better. But now you can go on and you can find out what the second lowest silver is. And if you want a gold plan, or you want to stick with an insurance company that doesn't offer the second lowest silver plan, you have to pay more. And I think it's only fair, given the cost of the premium, that goes away as your income rises. Otherwise, if you have one amount for everybody, you're going to be spending a lot more money. And remember, this was built off of a Massachusetts state plan where we picked the state with the lowest uninsured rate and we copied it, the best of federalism. So, and it was hard work. I mean, it'd be much easier to design a Medicare program where we offer one set of benefits, basically. There's some, it's not quite true anymore. But we tried to make private health insurance work, and as a result, it got a little complicated.
So this question, I'm gonna add some Tom Berlin into this question. There's one place I've spent a lot of time in, and that's hospitals. And in most emergency rooms and hospitals, there used to be a sign that said, no one can be denied service here. And while there are some private hospitals that don't have that sign up, most hospitals have that sign up. So this question has to do with people that are poor. And I think that's a concern, because of Matthew 25, that's a concern to most Christians, if not all. And it's a concern, I think, especially in a congregation like this that has a lot of outreach, where we are physically connected to people in poverty and want to have a congregation that includes all people. So now let me get to their question. Should basic health care be a right of every citizen of the United States? That's a yes/no question. So why don't we turn that into a question that you can give me more than a yes or a no. Should basic health care be a right of every citizen of the United States? And what do we do if we take away Affordable Care Act, what do we do for the poor person that walks into the hospital with no money?
Let me go to some. So I think, let me start by talking about Medicaid. We expanded Medicaid for poor people. A study came out last year that estimated the value that Medicaid recipients place on that coverage. the conclusion was that the recipients place about 20 to 40 cents of benefit. They receive about 20 to 40 cents of benefit for each dollar that the government's spending on their behalf. I think that suggests that the way that we have done it in the ACA is not cost effective. And it's not providing people, and I mentioned the study that, sort of the same study that said those people didn't get positive health outcomes from gaining access to Medicaid. I would say that the issue is really complex. There's a lot of things that affect people's health, right? And healthcare, if you were going to make a list of what are the things that affect people's health, healthcare would be towards the bottom of the list, right? At the top, you would have, I put a slide together of things that are more important to people's health than healthcare. Diet and nutrition, exercise, behaviors like smoking, where you live. Do you live in an urban area? People who live in urban areas tend to be more healthy than people who live in rural areas, tend to be more healthy than people that live in rural areas. Education is correlated to better health, right? So what we want is better health for people. So I think we should look at what the evidence is and try to produce policies that are consistent with better health. To the extent that we don't know things, instead of spending a whole bunch of more money on certain programs, I think we should do social experiments. So run experiments and see what works, right? Things are complicated. Poverty is very complicated. And sort of a healthcare poverty program should fit in with a general structure for how you would have an anti-poverty agenda.
Well, I think that's why we should have this discussion in church. What does it mean? The Bible says do justice. And, how do you define that in 21st century America? The Bible was written at a way different time. And I think, the command, love thy neighbor as thyself, means that we need to provide all individuals in our society the basic necessities of life if they don't have it, and we should demand personal responsibility, we should demand work, etc. But, there's a lot of things that Brian has said that I agree with. I don't disagree that we need to work on smoking. You will spend more. But, will you actually save the government? Yes, the smokers of the world probably help our Social Security Trust Fund. If I really want to get down to money, they die early. They don't collect Social Security as long. But
you'll find the smoking pole right out the front door, people. Just putting that in there.
It is important to one's health. There's no doubt about it. And so there's a lot of things that Brian has said that I agree with. The question is, how do we change that system? Now, Atul Gawande is a supporter of the Affordable Care Act. And he actually wrote an article about cost conundrum several years ago. And he shone a bright light on McAllen, Texas. And he compared McAllen, Texas to El Paso, kind of the same demographics, et cetera. And it turns McAllen, Texas was the second most costly hospital region in the country. Guess who gets the prize for number one? Miami. And we'll go there right now. But actually, because of the spotlight he shone on McAllen, I read Overkill on my way here, they have changed. They have reduced their spending on Medicare beneficiaries by $3,000. So I think the way you reform a system, and I think we tried to do that in the Affordable Care Act, is you focus on the providers. They have a lot more information. I actually think some of our better health systems, Geisinger, Intermountain, Kaiser, it's when doctors are supervising doctors, not government regulators or insurance regulators, I should say, or government bureaucrats. It's when doctors can see for themselves how they compare to other doctors. I've been briefed by the Kaiser hierarchy several years ago, and they were trying to get the doctors responsible for diabetes control. which ones had the A1C in the right level. So I think that's what we're trying to do, and that's what, the bill that I had the privilege of working on, and I actually didn't do the physician part. Boehner's staff and I worked on the financing of it. We are trying to make this a more value-driven, and I talked about the penalties on excess hospital readmissions. That's what we're trying to do, pay for value. And so I think the poor deserve it. I think, if you're the Medicaid director in Virginia and have to think about the homeless that come here, 1 week out of every 52, you have to be, I would say, godlike to figure out, what does that person need? Is he refusing treatment? Mental health is a little different than acute health. What's the right level of mental health? How do we get these? And a lot of our homeless have mental health problems or addiction problems of some kind. And, some addiction programs work, and it takes both the provider and the recipient, and it's hard.
Next question. Studies show that health care costs in the United States is among the highest in the world, but health outcomes are not. What, if anything, should be done about this?
We should spend less on healthcare. Right? If you're spending a lot of money that isn't doing much good, and if the federal policy is heavily subsidizing comprehensive health insurance, we should work to reduce the subsidies for health insurance. So there are a couple of ways to do that. The ACA, actually, I was talking beforehand with Wendell and said my favorite part of the ACA was that it tried to get rid of the tried to put the Cadillac tax, and it capped the exclusion the tax exclusion for employer-sponsored insurance. So basically, it limited the amount that was tax-free for employers to provide as far as health insurance. Now that is very unpopular, right? As Wendell knows, special interest groups in Washington like lots of health care spending, right? And businesses, labor unions, they've come together to push back on this part of the ACA. It was already delayed until 2018. So the ACA passed in 2010. This wasn't supposed to take effect until 2018. They've now delayed it 2 more years, I think in the SGR piece.
And the budget deal.
In the budget deal. That would be a positive step forward. I think to me, it's intuitive. If you are spending a lot of money on stuff that's not giving you very good outcomes, you should spend less money on it, right? We have a major, if you look at, I can show it, come up with. These are the long-term spending projections for the U.S. The yellow is healthcare programs. Healthcare programs, that's essentially Medicare and Medicaid and some of the Affordable Care Act, are eating up the entire federal budget, right? The red is interest on the debt. Interest on the debt is accumulating over time because we're not raising enough revenue to pay for all the spending on a yearly basis. And that's a major problem.
Yeah, that's another whole set of discussions that we can get into. But I do think we need to, and in the Affordable Care Act encouraged employers to do prevention and wellness programs. It remains to be seen how well they actually work. But again, that was one of the seeds we planted. But there's also a lot of health cost that has nothing to do with our health status. I mean, I had a cousin 10 years younger, much better fit. He had a stroke at age 57 or so, and he was in much better shape than yours truly. He was 10 years younger. He had nothing. I mean, it happened, and it was a large expenditure of money. And he, again, had employer health insurance. So we had lots of debates in the Democratic caucus about how do we incentivize those kind of things. And one of them was, should we penalize smokers? And, and at the end of the day, it's a part of the Affordable Care Act. It really hasn't been implemented that well. the president kind of tipped us in the direction because he thought it was right. But what you really want to do is change their behavior. And probably Tom knows as well as I, it's very hard to change people's behavior. And at the end of the day, I think people need access to health insurance, and we need to work on providers to do the right thing.
So some of your answers are covering questions here, so I'm going to pick a couple that folks here have provided. This person suggests that it feels as though all of our energy is spent on either defending or defeating ACA. Do you see much or any energy being spent to fix it? For instance, some items, it seems, should always remain. The coverage, up until the age of 26, no pre-existing conditions deny coverage, those sorts of things. I think what the person's focused on is, do you see much energy being spent on how to fix that? And if so, where is that energy being spent?
Yes, we are spending some energy. I just had a meeting where I called in various health experts a week ago, and we had a 4-hour session on the tweaks we would make. And a lot of it is better education, better outreach. I think Brian is right. We've done pretty well between 138% of poverty up to 250. We don't have enough of the subsidies between 250 and 400% of poverty. There are clearly things that ought to be done. Now, this election season, every Republican still on the Hill has said repeal it, and they're saying replace, but we have yet to see that. And, the Democrats, for the most part, are saying we support it. And I would say Capitol Hill is broken right now. We ought to be having those discussions. And, I have come to realize after 40 years of being in or around it, informed voters are the only way our democracy works. And, that's why, there are important decisions made in Richmond. There are important decisions made in the Capitol and et cetera. But yes, we ought to be working together to really make our healthcare system better. And that's going to take the work of both Republicans and Democrats. And we shouldn't be at odds anymore, in my opinion, about whether or not we should repeal it. I think whoever is elected, they're not going to take insurance away from 20 million. And at some point, I'd like a little more rebuttal time about enroll. There was a lot of things Brian said that could.
We will capture some rebuttal time for both of you. Duly noted. Brian, do you have anything to add to that?
No.
Okay. So I've got a question for each of you, and Brian, let's start with the one that's the person has said, Mr. Blaze.
Oh, let me say. I'm sorry. Let me say one thing about that. I think Medicare and Medicaid have serious concerns about how Medicare and Medicaid have worked, and I presented some of those. They both passed on a bipartisan basis. The Affordable Care Act passed without a single Republican vote. Right? There weren't a lot of Republican ideas. Wendell said, well, we copied what Republicans did in Massachusetts. The Republican candidate who ran for president in 2012 wanted to also repeal the ACA. He said, what we did in Massachusetts is not good for people across the country. Massachusetts is not representative of the United States, right? So policy that may have worked in Massachusetts, and Massachusetts started with about a 4 or 5% uninsured rate, right, when it did Romney Care. Massachusetts is very different from Texas. So I think when you're in Texas, and you're like, well, here's a program that's modeled on Massachusetts, implemented in your state. People in Texas aren't gonna, that's not the way to build political consensus.
Okay, but we would have to argue that people in Texas won't be happy about it either way. I'm sorry, I couldn't. I really couldn't resist. If you're from Texas, I'm also sorry, but not as sorry as I'm sorry about interrupting Brian. Okay. Mr. Blaze, President Obama repeatedly said, and that's Dr. Blaze, by the way, whoever wrote this, if you like your health care plan, you can keep your health care plan. To put it very charitably, he was wrong. How many millions of Americans are paying dramatically more for their health insurance or no longer have it because of Obamacare?
The president admitted in 2013 that he never should have said that. I think at the time everyone knew that that was not going to be the case, that people were going to lose their health insurance if they had insurance that didn't comply with all of the requirements in the ACA. And it's not, Wendell said there is, he said choice, and he gave platinum, gold, silver, bronze. That's the only choice. The only difference between those policies is the amount of cost sharing. All the policies have to cover the exact same set of benefits, right? There's no choice in, if you are a woman, you have to get coverage that covers prostate exams, right? I mean, every insurance plan covers the same thing. I think the estimates are that 6 million people lost their health insurance that they had because of the president's promise. He then reversed that promise later, or he reversed that policy and allowed people to keep non-compliant coverage, and that coverage continues now in many states, and people are going to be allowed to keep it, I think, until next year. It's hard to know exactly how many people premiums went up for. The premiums went up most significantly in the individual market. So the individual market had 12 to 15 million people purchasing premiums. The big changes in Obamacare happened in 2014. The Manhattan Institute had a study that premiums on average went up 50% between 2013 and 2014. Now the coverage was obviously much different, right? It provided a lot more benefit, but premiums went up for millions of people.
Will, anything you want to add to that?
Well, all I'll say is that premiums relative to historical levels have increased much slower the last few years, and that was partly because of the recession. But even now, again, premiums are going up at a slower rate. And I think this gets back to the fundamental part of insurance. You've got to have something that covers the healthy as well as the sick. I mean, remember that chart about how skewed the spending is. And Brian, we don't want you to be covered by insurance that just covers the cost of prenatal care and the cost of delivery. I mean, that's what you'd have to pick. We want everybody that's in the pool to pay for that kind of care. The people that have diabetes, the children that started with A1 diabetes and will probably have it for all their life. That is the nature of insurance, and I think you've got to make competition work in the market, you have to have certain rules and regulations. Otherwise, you'll go back to the cherry picking that we had before. You're right. That was a mistake by Obama. We went back at the time and tried to make sure Pelosi never said that. But it was. I mean, and there were skinny plans, et cetera. So some people had to change. But healthcare costs overall in this country right now have been increasing at their slowest level in the last 50 years.
When you said cherry picking earlier, I want to make sure I understand, that's the practice of a healthcare company saying, I'll insure person A because they're low risk, I won't insure person B because they're higher risk.
Right.
Okay.
And the good Lord made us all equal, but not with respect to, some of us are born with certain conditions that will definitely make us more expensive throughout our lifetime. I think all of us then have a collective responsibility to try to share those costs.
Let me see, that's true, but people also, there's also a moral hazard issue, and people's behaviors often determine what their health status is. And I would say one of the Obamacare, by requiring insurers to offer coverage to anyone that applies at a standard rate, provided an incentive for people to wait until they got sick to purchase insurance. And one of the things that we're seeing is that people are doing this. And these non-compliant plans, these plans that don't satisfy Obamacare's rules, are still being offered because people are buying these sort of short-term plans that are actual insurance that cover catastrophic expenses. So they're not covering sort of first dollar, everything, and all of the benefits that Obamacare requires. They're actual catastrophic insurance plans, so they have high deductibles. And people carry these policies knowing that if they get sick, they can drop that coverage and sign up for an Obamacare plan and not be penalized for the fact that they are now sick when they're signing up for coverage.
We'd like to work with Republicans to fix that.
But Wendell, you were nodding your head. You would agree with that last
Yeah,
statement.
and actually, I mean, the insurance companies, I've been lobbied many times on this in the last few months. We are trying to fix that so that people don't just enroll for part of the year and have their health expenses and then get out. I mean, healthcare, again, go back to the group market, the employer plan. I mean, as long as you're with that company, you're covered continuously, and that's what we're trying to do here in this kind of hard market, the individual market, et cetera. So we're trying to duplicate those same rules.
Next question, and you had a slide up, I think it was your last slide that you kind of bounced through, and I'd be interested in hearing from both of you. The person asked, is there really, the word really is underlined, are there really no death panels? A phrase, as you know, the phrase was made popular by Sarah Palin and actually had real impact on the voting related to all this.
Yeah, so I'm going to stand up for a minute because I actually want you to see that quote. Is this mine?
That's yours, yeah.
I think you're going to have to turn your computer back on. It went to sleep.
Well, Sarah Palin had a quote. I'll read it to you, assuming I can find it. And it was, you're going to stand in front of a government bureaucrat and have to justify your productivity to society, and that's how long we'll let you live. I mean, that was essentially, where is this? I'd like to actually read it verbatim because here it is. So here's what the quote was. It was in August of 2009 when the members had gone out to explain the Affordable Care Act. We had just gotten it through the committees, and she said, seniors and the disabled will have to stand in front of Obama's death panel so his bureaucrats can decide, based on a subjective judgment of their level of productivity in society, whether they are worthy of health care. Now, again, I would not accuse Brian of saying something like that. I mean, that was just so far from the truth. There were two things in the bill that were actually put in there by members who had lost their spouses. They wanted to encourage advance directives, and they wanted to give Medicare doctors more time to explain to someone, what are your choices? If you go down this route, what's going to happen? If you go down this route, what will happen? Most Americans do not want to die in a hospital. They want to die at home. And, we've had a 500-page Institute of Medicine report since then, basically justifying these two small baby steps that we took in the Affordable Care Act that had to be actually yanked out because of that. 40% of the elderly, according to a Kaiser poll, 35, 40, I can't remember the precise, believed the Sarah Palin quote. And just to give you an idea, in the 2008 election, the Democrats and the Republicans split the elderly population over 65. In the 2010 population, we lost the elderly by 21 percentage points because of that quote and the other one that we had cut Medicare. Now, that's the year we lost 63 Democratic seats. So knowing what the truth is very important. I can go on about death panels. Our society needs to figure out. I think the government should not dictate your end-of-life care. But it should help your provider and reimburse your provider so that you have choices and you know what those choices are. Go read the IOM report, but it was one of the things that in this society of ours, it's just very hard sometimes to get the truth out.
You want to add anything?
I would agree with that. I would say the government also shouldn't dictate your during life care.
In terms of the death penalty piece, I do want to say as a pastor, that's a space that end-of-life decisions are spaces that we're sometimes invited into. So just recently I was with two doctors and a family as they were making a very hard decision about life support. And in the time that I've been in ministry, there has been no change in how those decisions are made that I've ever observed. Except that doctors are far more consultative now and more likely to involve clergy in the conversation than they used to be. Let's see, where we go from here. I'm looking for short. I'm not sure what. Oh, okay.
Keep going.
Listen,
Short on both sides.
Well, the problem is if you put 4 questions, like that puts me in a hard space. So, why do European countries have lower cost and higher outcomes than the United States?
Well, there's a lot of complicated answer to that. Well, part of it, like Great Britain, does have government-produced health care. The government hires the doctors, hires the nurses, et cetera, and they are all government employees, much like our veterans' health system. And as a result, they do control the health care. I mean, Brian's giving me a little grief. You know, in the Affordable Care Act, it's still whatever your doctor and you determine is the right kind of care. Now, we have tried to make the providers smarter, and we have tried to, you know, again, penalize hospitals, et cetera, et cetera. So we have some provider incentives to drive them to the right place, but we don't tell them you can't do that test or you can't treat that, et cetera. There is none of that in the Affordable Care Act. But, you know, if you, through your government, you know, I could argue, for example, Fairfax County hires the teachers. You control the education costs by, you know, your teacher ratios, et cetera, et cetera. We do not do that in healthcare, and that's why we spend a lot more, because once you have an insurance policy, you know, then insurance company reimburses and the doctor can do extra tests, et cetera, and no one has to pay for that in at least that individual doesn't.
I mean, I think one of the reasons that we spend a lot more on health care in the U.S. is that doctors in the U.S. make a lot more than doctors in other countries, right? We pay providers a lot more. And I tried to make the case that health care and health insurance is pretty overrated relative to what we spend on it. So I think it's not surprising that we don't get as good a value for our dollar.
This personal responsibility thing is so hard in American society because most of us believe in it. But if you look at the average American in terms of our rate of obesity, our rate of diabetes, our rate of exercise, all the factors that you just put on that screen, I think most studies would show that we are not the best at self-care. Can government ever change that? I mean, is that something, well, better stated, in what ways could government change such a thing? Because every study I've read about healthcare says it's really about prevention. It's really about what your family doctor is trying to tell you. And yet most Americans simply aren't great at that. So I'm just curious, is that something that government can ever fix, or is that a function of the citizenry that resist policymaking?
So we have seen a significant decrease in smoking over the past, I don't know, probably at least 50 years. And I think that is partly social stigma, partly government has pretty significant taxes on cigarettes. But I think you're right, and Wendell said it earlier, and I agree. It's hard to change people's behavior. And I mean, one of my concerns with government policy is the moral hazard issue. When you provide, lots of income-based benefits for people, that presents a disincentive for earning additional income. Health insurance has a moral hazard problem, right? Insurance in general has a moral hazard problem. If you have car insurance, you are more likely to be an aggressive driver than if you didn't have car insurance, right? Same with health insurance. If you have health insurance, getting sick is less costly than if you don't have health insurance. Now, I'm not saying that you shouldn't have health insurance. I think everyone should have a health insurance plan when those catastrophic, in the unlikely event those catastrophic events come up. But insurance has negative consequences as well. So I'm not sure, I don't think there's a full answer to your question.
Well?
Yeah, I think government needs to be involved here. We have a bill now that I hope will actually be passed on a bipartisan basis. It's opioid-related deaths have now exceed traffic fatalities. And I think you can say doctors have overprescribed opiates. You can even say there's a little bit of incentive because we reimburse to some extent on patient satisfaction. And part of that is taking into account pain. But there's a case where I think with bipartisan action, we need to lower the number of deaths due to opioids. Brian mentioned smoking. Tanning beds, I learn a lot from the lobbyists that come. And so, I learned very quickly from a dermatologist at the University of California, San Francisco, there is no such thing as a safe tanning bed. Now, depending upon your choice, does that mean we should outlaw them? Does it mean we should educate? So in California, they have passed a law that says teenagers cannot use tanning beds. In the Affordable Care Act, we put a small little tax on tanning beds. Now, again, I'm not saying what is the right way to change human behavior, but I think everybody should know the consequences of that. And I think, we can go through a bunch of other, and I think making providers care about, your health, your obesity, et cetera, that's what we need to do, and we need to keep at it. And public education there, I think, is a very important thing that we need to be doing.
This person asks, why has there been such a rise in the astronomical rise in prescription medicine, and what can we do to stop it? Is that something either of you feel qualified to?
Well, in California, and I think in other states, you have set up registries so that the individuals who are craving the opioids cannot go to one doctor or one pharmacist and then go to another. There's a registry that shows that they've just been there already. And, I think the doctors have realized they need to do more education. The medical schools have stepped up and say we need to teach more about this in medical schools. And, the very fact that we have a crisis and there's a lot of publicity about it, I think it's not just government action. There has to be steps in many different places in our society, and I think we can do better.
Yeah. Anything you want to
add?
Yeah,
I mean, I think you have, part of this is an issue with problems with the entitlement programs with Medicare and Medicaid and the third-party payment issue, that there's not a lot of oversight and people aren't spending their own money. And I know with, we did, when I was at the Oversight Committee, we did work on New York's Medicaid program, and they had significant problems in New York City of sort of bad actors finding people on Medicaid to go and purchase drugs and then give them to the bad actors to then distribute.
This person writes, so often we look to government to solve big problems and issues in society. The result is big government policy and legislation that often doesn't work. I believe that these are cultural issues and a lack of individual responsibility. How can we change our culture to solve these problems instead of expecting government solutions and government bailouts? That's similar to what I asked.
Right, right.
Good question. Whoever's out there. Do you have anything to add that you haven't added?
Could I spend a minute talking about the promises we made to the elderly and the long-term spending projections that are up there on Brian's chart?
Feel free.
Okay. So, this, I think, so this is the demographics. I'll give you two factoids. Between 2010 and 2035, the number of us that are over 65 is going to double from 40 million to 80 million. The percentage of us that are over 65 is going to go from 13% to 20%, about a 50% increase. We spend well over $40,000 per elderly person in this country in the form of Medicare, Medicaid. And when you think Medicaid, think of nursing homes. My mother was in the nursing home for 13 years. She was, for the most part, paralyzed. And, she never had a heart attack or cancer or things like that. She died at almost 97. But that was very important care, and that's all figured into our health bill. Now, where am I going with this? I think those entitlement programs aren't excessive. Most of you who are on Medicare have probably purchased a supplemental coverage because Medicare today doesn't have an out-of-pocket limit. Medicaid does not pay doctors. A lot of doctors don't want to take Medicaid because the reimbursement rate is so low. And a good part of Medicaid is that nursing home care. We can afford, and I think it's very important as a Christian, and collectively we keep our promises. That doesn't mean that we can't tweak Social Security. I was a Ways and Means staffer when we did the 83 Social Security amendments. We raised the retirement age to 67. It has to be raised yet from 66 to 67. That will be implemented. But my point is that our society is to keep those promises is going to have to increase revenues by about 2 percentage points of GDP. That was what was in the president's budget. And politically, raising revenue or cutting spending are hard. But at some point, Republicans and Democrats are going to have to get together and figure out how we keep those promises to the elderly, which is most of you in this room, in Medicare, Medicaid, and Social Security. And we can do it. The world will not come to an end if our revenues go up a little bit. There's been enough income inequality that, I think for the most part, not completely, we can get it out of very high income earners, et cetera. But I just think it should be an important election issue, and I think it needs more discussion because I have yelled, would be the right term, at people like ARP who I think need to educate the country about our demographics and the implications for federal budgets. And I agree with Brian, Medicaid is squeezing out education, and right now, in my opinion, we're making kind of dumb decisions because those entitlement programs do keep climbing, and we're not making investments in infrastructure, NIH, and other places. But we can afford to keep our promises. We can tweak these programs a bit, and I think I think most people are very satisfied with Medicare, et cetera.
So, make a couple points about that. Social Security and Medicare, for those of you who are familiar with Ponzi schemes, the financing for Social Security and Medicare is very much like a Ponzi scheme. The initial people who retired and got access to these benefits basically didn't pay anything in, and yet reaped a huge windfall from the program. That worked because there were a lot of workers supporting each person who was retired and receiving benefits from the program. Over time, as the population has aged, there are fewer and fewer workers supporting each retiree on the program. I teach about how Social Security and Medicare work and to undergraduates, and they think generally that there are accounts that people earn, they pay into, and then they just collect from these accounts when they retire and receive benefits. Like, that's not the way Social Security works, right? The current person who is on Medicare right now, they're receiving $3 in benefits for every $1 that they paid in. Now, most people on Medicare don't realize that. They feel, well, I paid into Medicare, and now I'm going to get benefits from the program. And Wendell's right. I mean, it's very hard to trim these programs that people feel like they're entitled to, and they've paid taxes in. But the financing is unsustainable, and I don't think we're going to solve our way out of this sort of demographic issue by raising taxes on wealthy income earners. I mean, I saw data today, the top 1% of people in the U.S. pay 45% of all income taxes, right? The tax code is already very progressive, a federal income tax. On Medicaid, so Medicaid is commonly, so I think Social Security and Medicare both need fundamental reform. One idea I would do is increase means testing. So if you are a wealthy senior, I think you should probably get a smaller benefit than if you're a poor senior. The programs already have some means testing, but I think the means testing should be increased pretty significantly. I spent a lot of time while I was with the Oversight Committee working on Medicaid. Medicaid is typically thought of as the health care program for the poor. I did a trip around the state of New York, and we visited with Medicaid eligibility workers. And they said the typical person who applies for Medicaid in Long Island owns a home worth at least $500,000 and has several hundreds of thousands of dollars in their retirement assets. Why? Well, Medicaid, which, remember, it's supposed to be a program for the poor, allows people on the program that have home equity of up to $800,000. Right, so the program is not just for the poor. I think it would be, if we're going to have a welfare program, right, if we have limited number of federal dollars, we should try to keep those federal dollars on people who actually need them, rather than sort of have these universal programs where we tax everyone and give benefits to everyone and that are just unsustainable.
Yeah, I disagree fairly strongly. So there's a chart there on Medicaid, and you can see that the disabled, I mean, here's the number of enrollees today, 68 million, and the expenditures. And the disabled and elderly are 63% of the cost and only 24% of the beneficiaries. You know, children are relatively cheap relative to the elderly. Now, I think Medicaid is not overspending. I don't know about the 800,000. I mean, I grew up in Iowa. Yes, some farmers got, sent their farms to children so that when they got to be 85, 90, they didn't have any assets, so to speak. And you usually have to have pretty low asset levels to qualify for Medicaid, and there's a spend down, et cetera, et cetera. But that is a very important program. Again, most doctors don't think they get nearly enough out of Medicaid. So if anything, we had in the Affordable Care Act, it went away, that we wanted more doctors to be in the Medicaid program, and that's going to cost money. And it goes to, I don't want a second-tier health system where the elderly can only go to certain doctors and the rest of us can go to all doctors. Again, that violates my sense of what is proper. Now, again, I believe in individual responsibility. I do think every one of us, needs, that has income, should have health insurance, et cetera. And I don't think it's unsustainable. I think, again, with 2%, and we have lowered spending a lot in this country. Discretionary spending, non-defense discretionary spending, is at Eisenhower levels in terms of percent of GDP. Our defense budgets have come way down too as a percent of GDP. And yes, we probably still spend more than Western Europe, but there's a limit to how far discretionary spending can go, and we can afford those entitlement programs.
So this question gets back to that issue about the just debt and the impact that has on our society. With a published debt of $19 trillion and unfunded liabilities of the U.S. government of hundreds of trillions, how can the ACA not add to the debt as revenues from the program are not keeping up with cost? The insurance companies are incurring huge losses, which ultimately will need to be paid by taxpayers.
So the unfunded liabilities, just so everyone's clear on that, that's a measure of what government is expecting to make in what it's promised through these programs, particularly Medicare and Social Security, relative to the income that's coming in. I do not believe that the ACA is going to reduce the deficit. Wendell cites estimates, but the estimates rely on pretty shaky assumptions of cost controls within the ACA. So the ACA had two main levers that paid for all the new spending. Tax increases. Wendell mentioned, I think, the smallest one, the tanning bed tax, but there's significant tax increases in the ACA that I think over the next decade raised more than $1 trillion. And the Medicare, Wendell didn't call them cuts, he called them improvements. But the Medicare cuts are potentially unsustainable. The CMS, Centers for Medicare and Medicaid Service Office of the Actuary, said that if the Medicare productivity adjustments, if the cuts go into place, 40% of hospitals within, 15 or 20 years will be operating in the red, 70% of nursing homes would be operating in the red, and 90% of home health agencies would be operating in the red. So I think it is a very open question. And the Cadillac tax, which I mentioned, was one of the cost savers in the ACA and has been delayed. And I won't offer to bet Wendell here, but I doubt that the Cadillac tax ever takes effect.
Yeah, that's actually one of the things Methodists are against, is betting. So no, none of that.
So I think the ACA significantly increased government spending on health care, and on paper has reduced the deficit because of tax increases and Medicare cuts that may be unsustainable.
Sorry, Brian, I beg to differ, but actually, again, we just had a recent report from CBO that says, I'm going to get to the right chart here.
Tell people what CBO is.
CBO is our impartial scorer, Congressional Budget Office. They're not controlled by Republicans or Democrats. They have to estimate every piece of legislation that goes to the floor. And they've been asked many times to recost it out. So what this chart shows, in January of 2010, the projection for Medicaid and Medicare in 2020 was essentially $1.5 trillion, okay? Now, in January of 2016, for the same year, 2020, we've added Medicare costs have gone down, that's the dark blue. The next one is Medicaid, and then we've added the exchange subsidies. And remember, we've also expanded Medicaid. So that's all in there. So the actual cost here is actually lower in 2020 than CBO projected in 2010, even with the Affordable Care Act. And yes, Brian is right. There were also lots of taxes. About half of the Affordable Care Act was outlay reductions, and half was increases in taxes. So that's why I'm fairly confident that that CEA chart that I showed, that in the second decade, the ACA, even if Brian is right, and we have to go up a little bit on some of the cost subsidies, et cetera, we're good. So here, that's the growth in per enrollee spending. So in here you have private insurance grew 5%, and then from 2010 to 2013 it was 1%, and the yellow is for 2014. There it is in Medicare. That is what happens to growth in premiums for employer-based coverage. Again, I'm comparing 20 to 2010 to 2010 to 2015. So we have slowed down spending, again, not all because of the ACA, but that's why, I'm a firm believer that this law is good, even though we haven't made a very good case to the American public yet. And again, this is not the end all. We still have a lot more to do to strengthen the Affordable Care Act, to give incentives to doctors to do the right thing, et cetera.
So I want to give each of you 5 minutes to say whatever you want and about healthcare broadly. And just to let you know, if you're like, well, I don't have anything left to say, which I severely doubt, I think that what you could talk about, what the questions that I did not get to talk about are the need for education and also concerns about how lawyers and litigation affects the cost of health care. So if you want to put anything on that, you can, but you may have things you're holding on to that you want to get back to. So again, let's take 5 minutes. And Merv, do you have a watch? Would you hold up at 3 minutes, 2 minutes, and 1 minute for each of them? Because I did a really terrible job earlier, so if you would do that, that'd be great. And
who do you want to
Brian,
go
why don't we,
first?
yeah.
So this is my closing statement, where I save everything.
If this were a debate, it would be your closing statement. I really do mean this. Part of what I'm trying to do is to help people have conversations, but it is sort of this is your last 5 minutes.
So first, thank you, Tom, for putting this together. Wendell, really a privilege to be here with you, and thank you all for coming. This is great. It's great you get to do this every week, where you get to,
just talk,
sermonize to
I
people.
know.
Yeah, I mean,
awesome. Seriously, it's like opioids. You can understand why.
I think fundamentally, for me, I'm very interested in healthcare policy because I think we spend an enormous amount of money that does little, if any, provides little, if any, benefit. And the U.S. is on an unsustainable fiscal trajectory. I don't think we should be leaving our children with $43,000 of debt. They didn't have any say in how we were going to design the healthcare entitlement programs. They shouldn't bear an enormous amount of the responsibility for paying back promises that politicians have made that are unsustainable. Now, there's a lot of political factors that make reform difficult. Interest groups are heavily invested in maintaining the status quo and in spending more money in the healthcare sector. And I think what we need to do is not be afraid of change. I think we need to be open to reforming these programs so that they still provide the promise to people that have come to rely on the programs, but also where they're not working, and where I tried to go through evidence of studies that show we overrate the value of medicine, that we reform these programs in ways that allow for sort of consumers and providers to both have incentives that focus on the value of care instead of consumers having incentives just to spend because 90% of everything that they spend is paid for by somebody else, and providers just to make more income when they do more studies or do more services. I think fundamentally, I have one more graph that I can show. I think this issue, which is displayed on this graph, is one of the main problems that public policy has to face over the next, certainly over the near term. This is the labor force participation rate. And you can see, starting sort of with this recession, 2008, 2009, it's declined significantly.
Let me interrupt. When you say participation rate, participation in?
Participation in the labor force. So these are people who, the percentage of the population that is working or looking for work. The economy since 2010, right? It's when Obamacare passed, so I don't want to overly attribute this to Obamacare, but we had a significant recession in 2008, 2009. We've had a very weak economic recovery. In 2010, Wendell put on CBO's report. CBO estimated that real economic growth would exceed 3%. Real economic growth has actually been only 2%. Now, 1% might not sound like a lot, but compounded over time, the economy, right, what America's produces and what our income is 7% less this year than what CBO thought it would be 6 years ago. The people most negatively affected over the last 6 years are lower skilled workers, right? These are workers that these are people that Obamacare has given an incentive to leave the labor force. One of CBO's projections that Wendell didn't discuss is that CBO projects 2 million fewer workers over the next several years because of the Affordable Care Act, because the Affordable Care Act disincentivizes them from working. So I think fundamentally we need to think about policies that, one, will increase economic growth, and two, reorient the healthcare sector to a focus on value and less on just spend, spend, spend. Thank you.
I guess in my few concluding remarks, I want to hit this notion of Social Security as a Ponzi scheme. I think it's an intergenerational transfer where I allowed myself to be taxed, and my taxes essentially went to my dad and my grandparent. And yes, we now have fewer workers. My grandfather got the best deal. He paid in 1 year, and he lived to be 95, and he made out like a bandit. But that's legacy cost. We're never going to recover that. What Social Security is, if you die at 66, it's a very poor deal for you. If you die at 97, it's a very good deal. And I think that's what we need by a social insurance compact, because you can get 401ks, you can save, you can do other things. So if you want to pass that dollars on to your children, you can. I do not think our programs are unsustainable. I think with a small amount of revenue, we can take care of that demographic bulge, but it's going to have to be Republicans and Democrats working together. And yes, I can trim some benefits. I think one of the benefits that is unfair in our Social Security system is the fact that if I am a male and I have a second wife that's 20 years younger than myself, and I have children when I'm retired, my Social Security check is bigger. We will spend $30 billion on children of retirees, not children of survivors. I mean, if someone dies at age 40, just like Paul Ryan, Speaker Ryan got benefits, child benefits. But there are things we can do to these systems, and that change will not solve all the system. That chart is not terrible to me. It means that, again, it's just a reflection of our demographics. The baby boom generation, started in 46. They're about 69 or 70, and that's one of the reasons it's come down. Yes, we had a weak recovery, but we were losing 800,000 jobs a month when Obama took office. We turned that around, not all due to government policy, but now we've got the unemployment rate down to 5%. So I think the main thing I, as a Christian, believe is true is I want the poor to have access to necessities of life. I think that's what the Affordable Care Act was all about. And that is why Virginia should be expanding Medicaid, because to me, that's what we mean by love thy neighbor. And yes, it will require a lot of work by people to figure out what kind of health care. I mean, think of the homeless that come to this church. What do they need in terms of health care? How would you design the health care system for those individuals? But those are the kind of individuals that we made eligible for the Affordable Care Act through Medicaid. So I think our problems are solvable. I think Republicans and Democrats need to work together and keep our promises and improve the Affordable Care Act.
That's great. Thank you. I know that there is much more to be said about health care in America. I think that's all that my personal brain can manage for a night, though. So I just want to express my deep appreciation to both of you. And I appreciate both your candor with each other and with the group. But what I really want everybody to observe is the manner in which they had the conversation. That, to me, is the big missing link in American culture right now. And so I just really thank you for modeling that.